Welcome to Medical Mythbusters. I'm not going to go through the rules. Everybody knows the rules because we've all been here before and the format. So I'm not going to go through that. Welcome to Aloha Friday. I've gotten many comments on my shirt today. Just to let you know, this is the first time in 2 years that I haven't worn scrubs to the hospital. So it's a big day for me. All right, so the first, I guess, no disclosures. Nobody pays us. Keep trying, but nobody offers anything. Okay, so this is actually a clip that I used once before about 4 years ago, and it predates pretty much all of you, I think, maybe. So you haven't seen it before. It's about the only good clip I could find that has to do with kidney failure. It's not quite on topic, but it's because it's about kidney failure. I think it's worthwhile. For those of you older in the audience who remember Star Trek, this is from Star Trek. Maybe some of you guys have watched the movies or the reruns or whatever. So it's very short. And we will start.
What's the matter with you?
Kidney dialysis.
Dialysis? My God, what is this, the Dark Ages? Here, you swallow that. If you have any problems, just call me.
Fully functional.
So in case you couldn't understand what she said at the end there, she grew a new kidney with that pill, and she doesn't need dialysis anymore because her kidney is fully functional. So this first talk is about kidney failure. It's not about dialysis per se, but it's about preventing kidney failure and treating acute kidney injury. Something that we used to do for a long time, trying to use a magic, not a pill, but a magic potion called dopamine. And our first talk will be by Dr. Mary Henry, who will be talking about low-dose dopamine in the treatment of acute renal failure.
Okay. Hi, everyone. Thank you all for coming. My name is Mary. I'm one of the second-year medical residents, and my medical Mythbusters today is on low-dose dopamine and treatment of acute renal failure. So I have no disclosures. And then today we'll be talking about some fundamentals, dopamine synthesis and degradation, the receptors dopamine binds to, its use in the ICU setting. We'll be talking about the myth in question. We'll be going over some literature review, the toxicity, and maybe a potential replacement. So dopamine plays a significant impact to neurophysiology and hemodynamics, given its molecular properties. It's an endogenous catecholamine. It requires tetrahydrobiopterin and biotin as substrates. It's derived from the conversion of phenylalanine, tyrosine, and dopa. And neurologically, it's involved in reward, pleasure, and motor control. And hemodynamically, it's involved in different outcomes depending on the dose being administered. So as you can see here in the bottom slide, the biosynthesis, L-phenylalanine gets converted into L-tyrosine to L-dopa, and that's what gives us dopamine. So dopamine can bind to D1 and D2 receptors. The D1 receptor is located on renal, cerebral, coronary, and mesenteric arteries. And once it's activated, it relaxes vascular smooth muscle and increases cardiac contractility. It activates the G protein coupled receptor S, which activates adenylate cyclase. It's involved in the cyclic AMP conversion and makes protein kinase A. And what protein kinase A does is it increases calcium intracellularly in cardiac muscle, which increases contractility. And it also inhibits the myosin light chain kinase, which causes vascular smooth muscle relaxation. Dopamine can also bind to D2 receptors, and these are located in sympathetic nerve endings. And binding to the D2 receptor activates the G protein coupled receptor I, and this inhibits activation of adenylate cyclase and the whole formation of protein kinase A. So dopamine in the ICU setting. So like I said before, it's weight-based administration with low, medium, and high doses, all achieving different hemodynamic goals. So at low doses, less than 3 micrograms per kilo per minute, D1 receptor activation. This causes natural uresis and vasodilation of the renal arteries, diuresis, and an increase in splanchnic circulations. When the D2 receptor is activated, these are located on the presynaptic nerve endings. This causes inhibition of norepinephrine release. At intermediate doses of 3 to 10 micrograms per kilo per minute, this stimulates beta-1 adrenergic receptors, increasing cardiac output and vasodilation peripherally, and this is when we see the increase in renal blood flow. At higher doses, greater than 10 micrograms per kilo per minute, the predominant effect of dopamine is to stimulate alpha adrenergic receptors and provide vasoconstriction with an increase in systemic vascular resistance. Doing this increases afterload, which counteracts the medium dose, the intermediate dose I mentioned above. As we see in the bottom photo, when dopamine is infused at a rate between 5 to 10 micrograms per kilo per minute, we see the highest increase in stroke volume. But after 10 micrograms per kilo per minute, that's when we see afterload going up and a decrease in stroke volume. So acute renal failure is common amongst critically ill patients, and one of the most common causes we see amongst our patients is due to renal ischemia. And renal dysfunction is often associated with multi-system organ failure. The mortality of acute renal failure remains high, but animal data indicate that prevention and early treatment may decrease morbidity and mortality. So the use of race in GFR. So research in the late 1990s found that on average, African Americans had higher serum levels of creatinine. And this led to a change in the modification of diet and renal disease formula to incorporate a coefficient of 1.2 to account for race in calculating GFR. And this was developed in 1999. The eGFR is then multiplied by the coefficient to get the final result. But incorporating race into GFR calculations has led to several problems, such as the overestimation of kidney disease can lead to late or misdiagnosis. It implies race is a biological construct when it's actually a social construct, and it does not account for the diversity seen in individuals within the African American community. And studies have shown that African Americans are 3 times as likely as white patients to have kidney failure. So it's important for surveillance to be as accurate as possible. So some institutions, such as the University of Washington Medical Center, have already gone away from using race in eGFR calculations. One strategy is to determine eGFR in a way that's not influenced by race. And it would be to use a biomarker other than serum creatinine in the calculation. So researchers are currently working on formulas that do not rely on creatinine, but some task forces are recommending testing for cystatin C, as it's not affected by race, gender, age, or muscle mass. And cystatin C is a low molecular weight protein produced at a constant rate by all nucleated cells, freely filtered by the glomerulus. And a normal cystatin C level is on average 0.6 to 1.2. And the higher the level of cystatin C, the worsening kidney function. So acknowledging these disparities in medicine among different patient populations will allow healthcare providers to provide for the needs for the individuals that are most vulnerable. So low-dose dopamine, where did it all start? So in 1910, experiments on animals showed dopamine's effective vasodilation. And acute renal failure was induced in animals by clamping their renal arteries or aorta or by using nephrotoxic agents. And the effect of dopamine on renal blood flow and GFR were then studied. The animals in the experiment received a low dose of dopamine, so 0.4 to 6 micrograms per kilo per minute. And this showed better preservation of GFR, improved renal perfusion, and natural uresis by its activation on the D1 receptors in renal vasculature. However, it was unclear whether these effects played a role in the long-term survival of the animal. 1963 was termed the low-dose dopamine era. Scientists Goldberg, McDonald, and Zimmerman published a study in 1963 And these were the first scientists to demonstrate the renal effects of low-dose dopamine in humans. And they reported the effect of dopamine in 4 patients with CHF. And these 4 patients were started at a dose of 100 micrograms per minute of dopamine. And this was increased by 10%, adjusted every 15 minutes based on the effects seen, such as the rise in blood pressure and cardiac contractility. And they found that at low doses of dopamine, there was an increase in cardiac output and sodium excretion. A year later, the same scientists compared 2 arms, 9 healthy individuals and 6 patients with CHF, and they concluded that both arms experienced an increase in GFR and sodium excretion. So the myth, low-dose dopamine benefits critically ill patients with acute renal failure. So traditional animal and healthy human models of acute renal failure is that hypoxia and hypoperfusion to the kidney leads to acute tubular necrosis. And as previously mentioned, low-dose dopamine increases renal blood flow, which is expected to be beneficial in the treatment and prevention of acute renal failure. But the evidence of vasodilation is limited to healthy subjects in animal models. But the etiology of acute renal failure is actually multifactorial. Pharmacokinetics varies amongst critically ill individuals, and this can cause a lack of correlation between serum levels of dopamine and the actual dose being given, thus making dopamine delivery to the kidneys less accurate and less reliable. Dopamine plays a role as a diuretic that acts on the proximal renal tubules, which increases sodium delivery, increases metabolic activity and oxygen demand in already ischemic tubules of critically ill patients. So does dopamine worsen renal perfusion? Well, a crossover study design was done by Lushk et al., published in the year 2006, looking at the effect of low-dose dopamine, and it was evaluated based on renal indices using Doppler. This study compared 2 arms, 10 healthy patients versus 30 with acute renal failure, and they defined that as a creatinine doubling from baseline or an increase of 2 milligrams per deciliter. 2 micrograms per kilo per minute of dopamine and placebo were administered, and the results of this study showed that dopamine decreased renal vascular resistance in the healthy subjects, but caused the opposite in the acute renal failure patients, concluding that low-dose dopamine should not be routinely used in acute renal failure patients in the critically ill setting, as it worsens renal perfusion. So Bellomo published a study in 2000. It was multi-center, double-blind, placebo-controlled study of low-dose dopamine in patients with at least 2 criteria of SIRS and evidence of renal dysfunction, whether oliguria or a rise in serum creatinine. There were 324 patients in the ICU, 161 of them in the dopamine arm and 163 in placebo. And those receiving dopamine received it at a rate of 2 micrograms per kilo per minute, and the primary endpoint was to determine if there was an increase of serum creatinine. Results showed that dopamine neither helped with decreasing the peak serum creatinine or avoiding its rise from baseline. It did not decrease the length of stay in the ICU compared to placebo, and there was no change to the duration of ICU or hospital stay. There were 69 deaths in the dopamine group and 66 in the placebo group, so no significant mortality benefit, concluding that low-dose dopamine does not protect against renal failure in critically ill patients. So Frederick et al. Published a study in 2005. It was a meta-analysis with 61 trials and 3,359 patients that were randomly assigned. And all patients received low-dose dopamine. And results demonstrated that it did not affect mortality. It did not decrease the necessity of renal replacement therapy. It did cause a rise in urine output by 24% on day 1. It resulted in improvements of serum creatinine level and measured creatinine clearance on day 1, but both clinically insignificant. And no changes were reported on day 2 and day 3 of therapy, concluding that, yeah, dopamine can cause minimal urine output early in treatment, but no clinical benefits in patients with acute renal failure. Another study published in 1996 explored the relationship between the administration of low-dose dopamine and outcomes in acute renal failure. It was a multi-centered randomized trial with 256 patients with acute renal failure. Who received dopamine, and 93 deaths were documented, and the 52 patients who survived required dialysis during a 60-day period. The relative risk of death associated with the administration of low-dose dopamine was 1.11, confidence interval being 0.66 to 1.89, and the relative risk of death or dialysis associated with the administration of low-dose dopamine was 1.10, confidence interval 0.71 to 1.71, concluding insufficient evidence that the administration of low-dose dopamine improves survival or prevents the need for dialysis in patients with acute renal failure. So can low-dose dopamine prevent contrast-induced nephropathy? A study published in 1999 was done looking at dopamine preventing contrast-induced nephropathy in patients undergoing arteriography. There were 66 patients with chronic renal failure and or diabetes who received low-dose dopamine plus saline or saline alone over a 48-hour period. There was no benefit of low-dose dopamine over saline in these high-risk patients undergoing coronary angiography, and a subset of patients with peripheral vascular disease who received low-dose dopamine actually showed worsening of their serum creatinine. So low-dose dopamine is not without side effects. There are dopamine receptors present in the carotid bodies, and this can depress respiratory drive by inhibiting the chemoreflex responses during hypoxia and cause a decrease in minute ventilation. Even at low doses, it can increase myocardial oxygen consumption and cause myocardial ischemia, triggering cardiac arrhythmias. Given its action on alpha-1 receptors, it increases systemic vascular resistance, leading to tissue necrosis and digital gangrene. It can also cause electrolyte imbalances such as hypokalemia, hypophosphatemia, and can hasten the onset of gut ischemia by shunting blood away from bowel mucosa. So in summary, dopamine has been used in clinical practice to treat acute renal failure in critically ill patients. In spite of this long-standing utilization, there have been limited evidence, as previously mentioned, and given the involvement of alpha and beta receptors along with the dopamine receptors at different infusion rates, its use in clinical practice, especially in renal function, is limited. So is there a substitute? So dopamine has been compared to phenoldiprem, and as we see in the chart, while dopamine acts on all 5 of those receptors, phenoldiprem exclusively acts on the D1 receptor. It's been used in cases of hypertensive emergency and decreases peripheral vascular resistance, primarily in renal capillary beds. There have been a few studies on phenoldiprem in treating acute kidney injury, but these were limited due to a small amount of patients. And the most recent study published in JAMA 2014 was done among 667 patients with AKI after cardiac surgery. And 338 of them received phenoldiprem, 329 received placebo. And results showed that phenoldiprem did not decrease the need for renal replacement therapy or risk of mortality. It did not decrease length of hospital or ICU stay and actually caused significant hypotension. So it's not a good substitute. And that is it.
Does anybody have any questions or comments in the audience? Yeah, low-dose dopamine's been used for decades, as she alluded to. I think most people have gotten away from using it, particularly to try and prevent or treat renal failure, but I still occasionally see it used in the ICU by some attendings. And so I thought it was worth examining the actual evidence, even though I think most people have accepted the fact that it doesn't help. But not to bias you or anything. So is it a myth? Treatment with low-dose dopamine prevents and or improves outcome of acute renal failure. So how many of you think this is true, that low-dose dopamine is effective in treating or preventing renal failure? How many think it's plausible? How many think that this is just totally busted? Looks pretty unanimous. All right. You get, now let me make sure. Okay, now you just tap.
Oh.
Double tap.
Oh.